Hello, everyone.
Hello.
Hi, Larry.
Hi.
How are you?
Good. Happy holiday almost.
I know. Happy holiday to you too. Hi, Art and Donna. How are you?
Good to see you
Welcome.
again.
I love your shirt. Very vibrant.
Thank you. Thank you.
You're
I
welcome.
love the colors of our college, Oklahoma State. They're orange and, but this is kind of salmon.
That's still beautiful.
Thank you.
You're
And your
welcome.
lipstick matches, right?
Yeah, I tried.
See, even I noticed that. So it's fun to be a woman.
I didn't take time for any other makeup, but anyway.
So, Larry, while we're waiting for a couple other people to pop up, do we have the finalized date for the next one?
Yes, that's in 2 weeks, June 11th at 3 p.m. And we sent a draft flyer to Kayla. I don't know if she's on the line now, and asked her to distribute that so we can talk about that later on or Tuesday.
Okay. And then that's our last one. So we'll
Yes.
have to look at the calendar and see if this time works, or if we should do
Right.
it earlier in the day.
Right.
So we'll have to figure that out.
Okay. Yeah, Mark and I are meeting with some of the activity directors this week. We'll get some additional feedback from
Okay.
that.
What time is breakfast over usually?
Well, we have all day dining, so in theory, you know, you can eat at any time. I think most people are through by 9:30.
Okay. Because I'm almost thinking, I wonder if,
Right.
you
We
know,
can eat-
Donna, were you going to say something?
Apparently my internet's unstable. You're freezing for me.
Oh. Can you hear me now?
I hear you, but sometimes it's cracking up or delayed, but I hear you right now. It's okay. I don't think it's you. I think it's the internet here.
Okay. All right. Well, if it comes a problem, let me know. Larry, should we get started? What do you think?
Sure, yes. It's a couple minutes after. Let's get started, and other people can join us.
Okay, perfect. Well, thank you for coming back and learning about very important things. And for today, if hold on, I'm gonna unplug my devices so that they don't make any noise for you guys. That's better. So, and then it's always recorded. So if this is not a convenient time, then we could certainly, they could certainly watch it at a different time. And, you know, Donna, since you've pretty much been on every single call, I would encourage you to think about if you think this is a good time, or if this might be, you know, one of that sluggish time of day, if we should be doing it maybe first thing in the morning, right after breakfast, or, you know, or what you think would be a better time to capture people.
Or maybe some other day of the week, since Friday sometimes, you know, is the end of the week cocktail hour.
Right. So go ahead, Donna, what were you going to say?
Well, we have a happy hour on Friday afternoon, and it's going to be starting for us at 4 o'clock. But and we have exercise in the morning, usually around 9:45. So we can eat breakfast at any time. I don't know, it might be better to have it in the morning if possible. Maybe even say 10:30 or 11 in the morning, but I don't know how other people feel about it.
Okay.
I know I get really sleepy in the afternoons.
So do we all, especially on Friday.
Okay, so we'll explore that, and then Larry, maybe on Tuesday we'll connect and we'll pick some
Right.
other date and
Yeah.
time after
Right.
talking to everyone. Okay, all right. Well, why don't we go ahead and get started? and talk about what I think is probably the most important topic, how to talk to your doctor. And the reason why I say that is because just kind of looking at our roster here, if you guys remember, we did what's normal aging, cognition, depression, dementia, mobility, sleep, urology, memory screens. Now, how to talk to your doctor. I would have to say, out of all the lectures that we have given, this is the most important, really, for one reason only, and that is because you can't really Google this topic. You can't purchase a book on this topic. It's not a disease state or an isolated event. It's my experience as being that sandwich child, the child that has the older adult, the 85-year-old parent, and the young child. And then, so that's the patient component of me. And then the professional component of me is the recipient. So not only do I go with my mom to her doctor's visits, and I'm the patient side, but on the other side, as the physician, on the recipient side of the patient's concerns, I see it both ways. And so I think this is a very unique opportunity for you to see how to maximize your time with your physician. So let me just kind of set the stage where in 2021, visiting your PCP or your subspecialist is very different than when I entered med school in 1990. In 1990, we had a luxury of time. We did not have the paper trail that we do now. We did not have the electronic records. We did not have all this authorization and extra time consuming tasks. And there's only so many hours in the day. And as a result, in the past, I was able to sit down and have as much time with my patients, 45 minutes, an hour, to talk about family, talk about psychosocial issues, review medications, really do a very comprehensive visit repeatedly. And there wasn't so much on my mind as far as calling pharmacy to say, no, generic is not acceptable. We have to do the designer drug. So, there was much less distractions. There was just me and my patient. Now, life is very different. Now, a physician has a stack of charts, whether it's electronic or paper, that need to be signed. Pharmacy is always calling to see if they can change a medication to a more cost-effective medication. Physical therapy is asking for a script. And so it just goes on and on and on, the demands that are placed on the physician and the time constraints, not to mention the medical legal cloud that hangs over our head, which if you didn't document it, you didn't do it. So if we don't document everything that we see and have valid rationale as to our diagnoses, then we're putting ourselves at a legal risk. So with that being said, all those pressures on the physician, someone has to pay. So the physician is paying in that they're pulled in 1,000 directions, and the patient is paying because they're not getting that undivided attention with a larger quantity of time. It's depending on if it's a follow-up, it could be as short as a few minutes to as long as 45 an hour if you're doing a very comprehensive initial assessment. But for the most part, I would say it's more on the shorter end where it's very rapid, and it's not just you with the doctor. First, it's a medical assistant who comes in and does your vitals. Then you might have a scribe who's in the room with the doctor, so they write down whatever you say. So there's a lot of impersonal components to the visit. And then of course they have you in multiple rooms so that the doctor could go from room 1, 3, 4, whatever it is, in whatever sequence.
Yeah.
So you're sitting in the room, as these other people are gathering information, and then they present it to the physician, and then the physician spends a few minutes confirming what they have gathered and addresses your issues and makes a diagnosis and treatment plan. So why do I say all that? I say all that because in order for you to get the most out of your 10, 15-minute encounter, or if you're lucky, 20 minutes, 30 minutes, in order to maximize that time when you have multiple comorbidities, medications, and issues, not only medical, but psychosocial and preventative medicine, and how do you get that all in such a short period of time? So that's why I created this lecture, because I think it's critical for you to be aware of what we're going through and give you tools and tricks and ways on maximizing that visit. So the first thing you do is you have to have either a health folder, a loose leaf binder, or a spiral notebook with pockets in it. But you have to have your own area, location, where your medical documents are collected. And it's not only lab results and imaging results, but it's also your encounters, your list of physicians, and so on. So let's go through that. So everything I am recommending you do, I do for myself, because I not only have to monitor my own health, but I have to do my mom's and my 2 children. So I'm responsible for a lot of I's being dotted and T's being crossed. So first thing I would recommend is having, so for me, I have a loose leaf binder, and it's a white loose leaf binder with a plastic sleeve. And in the front of the plastic sleeve, I have numbers, and it says number 1, Susan's lab results, 2, Susan's imaging results. And I write down all the different important parts of my medical care, okay? Then I get dividers. And so 1 on that top list would match 1 on my divider. So if I'm looking for my last cholesterol level, I see, oh, lab results is number 2. Let me go to tab number 2. I go to tab 2, and there is a sheet protector. That's how I put my labs in there. There's a sheet protector, and I have the latest labs up front. And I do that with subspecialists, consult notes, and so on. So everything for me is in one comprehensive binder. Once again, you could do loose leaf, you could do spiral, however works for you. But the key component is that you want to have everything in one area, and it has to be extra organized. So in my tab that says preventative medicine, what preventative medicine do I need to know? So I need to know when am I due for certain testing. So you could certainly talk to your physician about it, or you can look at it online, what the recommendations are for screening. Let's just do basic screenings, okay? So let's just say you're looking for your colonoscopy, okay? And let's say you started it, or your children started it when they were 50. Who's gonna remember whether you should have it in 5 years or 10 years? before you know it, you blink and 5-10 years have passed. And now you're complaining of black tarry stools and you get diagnosed with colon cancer. And you say, now, how did that happen? Well, that happened because you lost track of time. So the important thing is to write all your preventative medicine screens, whether it's a pap smear, whether it's a mammogram, ultrasound, whether it's breast, cholesterol screening, whatever your screening is, and the frequency that's recommended based on your age, you should have a list. And then what you should do is say preventative medicine. So let's say, okay, I had my pap smear in 2020, and now in this folder, I have my results. And the gastroenterologist said, I should come back because I have some polyps in 5 years, okay? So what you have to have is a to-do list. And it will say next pap smear due 2025. And it has to be something that you look at routinely. So I look at it every time I go to the doctor. Now, if you're going for your annual physical, it's annual that you look at it and you say, I'm due for this, I'm due for that. And if you do have a centralized location of when you're due for your preventative medicine, then the chances of you forgetting about it or it lapsing is less. And when you're talking about prevention, I would also say routine. So vaccinations. When was the last time you had a tetanus shot? You're not supposed to get it every year, but who's going to remember when you get it? So lots of times if you step on a nail and you go to the emergency room, they say, when was your last tetanus shot? You see, gee, I don't remember. They just give it to you anyway. So that's not really good. So once again, you'd have to have a list of all the vaccinations that are due and when you last had it and why you had it. You stepped on a nail, that's why you had it, or you were simply due for it. So the tetanus vaccine, the pneumococcal vaccine, the pneumonia vaccine, and of course the COVID vaccine if you're going to be doing that. Okay, so that's an important schedule to have up. So each and every section has to be addressing something. So I started off with preventative medicine because I see, unfortunately, individuals getting diagnosed with cancer simply because these are the words they say, life got in the way. I forgot. I just didn't have a chance, or I've been so busy, or I didn't realize that 10 years have passed. So, and everything I'm saying now, not only does it relate to your health, but you should have a couple notebooks. You should have one notebook that's exclusive for your health. And then you should have one notebook that's exclusive for your finances. And the reason why I say that is because a lot of times when I talk to individuals and say, okay, I'm your physician, who's your healthcare proxy? And do you have a will, and who's the power of attorney? And the only reason why, I don't get into the legalities of it, but the only reason why is that if you're my patient and I see that you're starting to cognitively decline or you're advancing in age, I want to make sure that all your ducks are in order. And lots of times I'll hear people say, oh, I made a will. Oh, my husband and I made a will 20 years ago. We're all set. We picked everything. You know who's going to be our healthcare proxy. Everything's all set. It's in a safe, it's in our home, and so on and so forth. And the same person is the one who had the colonoscopy who said, yeah, I had a colonoscopy, not a problem. I'm all good. but when did you have that colonoscopy? And 20 years for a will is just too old. And the reason why I say that is because laws change. And perhaps the individual that you had identified as your healthcare proxy is not your healthcare proxy choice today. Or perhaps that person is ill and they can't be your advocate because they themselves are having problems. And this is a real example. I had a patient who had picked her sister as her healthcare proxy, and her sister was diagnosed with cancer, and she never changed that healthcare proxy. And her sister passed, and now she is in need of a healthcare proxy, and she doesn't have one. So keeping, once again, not only your financial, but your medical affairs up to date and looking at it routinely is the safest way to go. So we're still preparing how to talk to your doctor. So once you have your notebook or your folder, whatever it is, ready with all your vaccinations, your allergies, your screenings for your sugar, cholesterol, pap smear, colonoscopy, breast, then you need to have a section for notes. And it's Dr. Notes have to be about what happened during your encounter. So you went to see the doctor March 2020. Why? Was it your general physical? Was it a symptom related reason why you went? Is it that you thought you had COVID and you got tested for that? Or was it that you were having chest pain, or your foot was hurting, your back was hurting? What was the reason for that encounter? Okay. And what came of that encounter? And what you really need to do is every time you go to the doctor, you need to, as soon as you leave, sit in the car and write notes on what happened during that encounter. And the reason why I say that is because the doctor has given you a ton of information. And if you don't immediately transcribe it onto some notes, then you're going to forget it. And then you're going to turn to your partner and say, what did he say about this? And what did he say about that? And what happened here? And what happened there? And then you're completely lost. Okay. So how do you prepare going to the doctor? First thing you do, as I said, is you have your background. You have your notebook. You have all your data put in a safe spot. Second thing you do is you have to think of a doctor's visit like an interview. You have to anticipate what he or she is going to say. They're going to say, how are you doing? How are you feeling? They're going to say, we upped your cholesterol medication. Are you having any cramps? So you really want to, once again, act as if it's an interview and prepare yourself and anticipate what questions will be asked of you. And the reason why I say that is because when you're sitting there and you see that the doctor is rushed and they throw a ton of questions at you, you might say, no, I'm fine, everything's fine, I'm fine. And then you leave and you're like, well, I'm not really fine. This hurts and that hurts. And I should have told him this and I should have told him that. You don't want to get caught up in the moment. So you want to anticipate what is going to be said. Then you want to be in control. So if you're going in and you have, say, 5 questions or 5 concerns, you have to prioritize them because your physician may or may not prioritize them in your order. So you have to say, when the doctor says, hi, Mary, how are you? You're going to say, doctor, I have 5 concerns that I want to address with you during this visit, and I have prioritized them. It's very important because the last thing a physician wants is you come in and you're socializing, and now you don't have that 15 minutes. Now you're down to, say, 7 minutes. And he reviews your labs and medications, and then he's walking out with his hand on the doorknob. And it's just like today, Friday at 3:25 p.m. And you say, oh, by the way, I meant to tell you about that chest pain I had. I just got caught up with everything else. I'm sure it's nothing, but my wife is nagging me that I have to tell you. My husband's nagging me, I have to tell you. My son or my daughter's nagging me, I have to tell you. And then the doctor, you could see, is like, is taken back, because that's not something you should be telling as you're walking out the door. Okay. So prioritize it as to what is the greatest of concern to you, but list them. So say, I'd like to talk about me losing urine. I'd like to talk about this tightness I have in my chest. I'd like to talk about the pain I have in my back. I'd like to talk about me not being able to sleep. Whatever your issues are, list them down, you prioritize them, and then he will say, okay, we're going to tackle number 1 and number 3. We're going to tackle this and this today. And then you have to do a follow-up visit next time. Okay. So let's say you're complaining of difficulty sleeping. Okay. So you don't want to say to the doctor, I'm having difficulty sleeping. Can I have a sleeping pill? And if he turns around and says, sure, here's a prescription, that's the worst thing that can happen, because you don't want to take a sedative hypnotic for insomnia when the insomnia could be related to anxiety, it could be related to pain, it could be related to a noisy sleep partner, it could be related to restless leg, it could be related to so many other things. So how do you help your physician in making the right diagnosis for you? Anticipate questions, and don't go in there and requesting an immediate solution. So what you would say is, doctor, I'm having difficulty sleeping and it's affecting my quality of life. Can we review what the cause could be? You always want to work with your physician in identifying what's called the root cause of your problem. So if you're in pain, what's the root cause of my pain? If you're having difficulty sleeping, if you're having difficulty swallowing, if you're having pain in abdominal pain where you don't want to eat. So all these things are very, very important, because the root cause will lead you down the right diagnosis. So for example, I had a patient who who had her ovaries removed. She had a cyst, so she had her ovaries removed. It was a small incision, and she was discharged home. She was discharged with narcotics for incision pain. She was discharged with gas pills, and she was told that the nurse would be calling her the following day just to follow up and make sure everything is okay. So the patient had the ovaries removed, had small incisions, went home, and was complaining of left shoulder pain, and kept saying, well, maybe when I was on the stretcher, they hit my shoulder against the door, or maybe when they did the surgery and they transferred me from, one stretcher to another, something happened and I don't know about it, but why is my shoulder killing me? It's killing me. Okay? And then the nurse calls up the following day and says, how are you doing? And you say, not so good. I'm in excruciating pain. I have horrible shoulder pain. And the nurse says, well, what medications were you given? And were you given any pain meds? Yes, I was. So now the nurse says, well, we gave you the pain meds, so go ahead and use the pain meds. Okay. So now you use the narcotic and you have side effects as a result of narcotic, and then you call me and say, Dr. Varano, I had my ovaries removed. I have excruciating shoulder pain. The nurse gave me a follow-up call. They sent me home with medications, and I took the medication, and now I'm having a lot of side effects. I don't know what I'm supposed to do. I still have excruciating shoulder pain. Should I go to emergency? What should I do? So the importance of that is understanding all the sequence of events that cause that pain. So when she had the surgery to have the ovaries removed, they inflated air. They distended the abdomen so they can actually visualize where those ovaries are. Then once they saw it, they made the incision. They made the incision, they inflated air, they removed the ovaries, they stitched her up, and now her abdomen is full of air. And the air is below the diaphragm, and it's now radiating to her left shoulder. So knowing the history, understanding the pathophysiology, the right answer would have been, this is gas pain. I know it sounds weird, your left shoulder, but it's pain, referred pain due to gas that's trapped under the diaphragm that the physician had put into you, okay? And the answer is, do not use your narcotic, you use your gas pill. And once you use your gas pill, that'll relieve the pain. So she went ahead, took the gas pill, and within no time, the pain went away, but she still had the side effects of the narcotic. So why do I say this story? The reason why I say this story is when you're describing pain to your physician, or insomnia, or constipation, or incontinence, whatever it is, you really have to paint that picture. You really have to give them as much detail as possible so they make the right diagnosis. So let's take insomnia. Rather than saying, Dr. Smith, I can't sleep at night, can I have a pill to sleep? And he says, or she says, yes, here's your script. You want to say, Dr. Smith, I have a hard time sleeping at night, and I've done a sleep diary. And I realize that there's nothing that I can do to correct it. So I go to sleep at 10 o'clock. I don't take naps during the day. I sleep alone. I don't have a sleep partner. But what I've noticed is when I'm laying down, my mind races and I get very anxious thinking about all the things that I have to do and all the fears that I have. And so I can't sleep. That is a beautiful presentation that a physician would embrace and say, okay, then let's give you a low dose anti-anxiety medication and see if that soothes you. In addition to, you could take some chamomile, relaxing music, make sure the temperature in your room is appropriate. If you believe in meditation or yoga, you could do that. There's so many non-pharmacological interventions to decrease your anxiety that promotes hygiene. Let's do that before we start a sedative hypnotic on you. So, but your physician would never be able to give you those tools unless you had shared with him or her, your sequence of events. Now, when you are preparing for your doctor's visits, in between the doctor's visits, you have to have, once again, a diary where if, for example, today I'm feeling sharp chest pain, I write it down. And then if, for example, on June 3rd, I'm feeling dizzy, I write it down. So every time you feel a symptom, you write it down. and write down, you just don't write down June 3rd dizzy. You write June 3rd, 95 degrees outside, gardening, went from squatting position to standing, was dizzy, sat back down, drank water, and it went away. Okay. That's a very different scenario than I was walking and it was not hot. I was not dehydrated. And all of a sudden I felt palpitations in my chest and I got dizzy. Okay. So the first scenario is very consistent with someone who's dehydrated and they have an orthostatic hypotension type of picture. The second scenario could certainly be an arrhythmia. So different pathways to go down. So you really want to document in your diary and explain in detail the symptoms, the concerning symptoms that you have and the circumstances surrounding it, even if it's emotional. So let's say your grandchildren came over and they upset you, or they excited you, or whatever, or you got into an argument, or you worried about something. Those emotions obviously trigger releases of in your body of hormones and whatnot that can lead to physical manifestations of illnesses. So you want to write that down. So in between each visit, you want to have a diary of symptoms. Then I would say about a week before you're going to the doctor, review that diary and say, you know what, this only happened one time. I don't think it's relevant. I'm going to delete that. Or, wow, look at that. This is happening over and over and over again every day at 3 o'clock, or not every day, but every week, or whatever it is. I'm feeling this certain way. Or isn't that interesting? I'm laying down and in the morning when I wake up, I all of a sudden have vertigo and then it goes away after about 10 minutes. And it's happened 5 times in the past 2 weeks or 2 months. So that pattern with time associations and circumstances surrounding it will really have your doctor either make the right diagnosis or put a halter on you or send you to neurology. Or in some circumstances, if you have a good enough story, they might even send you to the emergency room. So it's very valuable to learn how to share what you're feeling in a very concise, straightforward way, just very data driven, try not to make, just try to explain, explain the circumstances. I was upset, had a disagreement with daughter, created a lot of, anxiety for me, and this happened. Don't go into the details of why you had a disagreement with the daughter, because then you go off on a tangent, and that's not so good. That'll take too much time. Okay. So in between your sessions, you do that. Then before your session, you consolidate. And then that's where your priority is coming through. You're prioritizing what you want to have discussed. Okay? Then you want to have always at your fingertips your list of medications. So you have 8 to 10 medications, and you need to include over-the-counter medications, which are vitamins, supplements, topical medications, patches. Everything has to be included. And what you want to do is you want to make sure that everything you're taking, your physician has on record. And the reason why I say that is because he or she will see that there's drug-drug interactions that you may or may not be aware of. So some medications are cleared by certain pathways, and if you're on another medication, then that could be a problem. So for example, some overactive bladder medications are cleared by this, it's called a cytochrome, it has a lot of letters to it, but it's a cytochrome clearance system, and metoprolol is cleared by that same system. So if you have an overactive bladder medication with metoprolol, you might be getting a less effective dose. Okay, so you definitely want to have all your medications down, and you want to have the dosages down, and you want to have the indication. So why am I taking metoprolol? Why am I taking Lasix? Why am I taking cholesterol lowering drug? You want to have each medication matched up with a disease state. And then you want to have in your notebook, when was the last time we reviewed this? So if I started digoxin, 20 years ago, and the philosophy is it's not hurting me, so why should I stop it? That's not a good philosophy. You have to know, why did you start the digoxin and what's your ultimate goal? So anytime you start a medication, you want to know, what is my goal? Is my goal to lower my blood pressure, lower my cholesterol, lower my sugar? Simultaneously, I'm going to try to lose weight and exercise and change my diet, decrease my stress. You have to have a goal. And if the goal is ultimately to eliminate the medication, then when you're going to the doctor, you can say, okay, Dr. Smith, it's been 8 months since you started the cholesterol medication. I've lost 10 pounds. I've changed my way. As you can see, my cholesterol's in good shape. Is this a time for us to taper down? So when you're going to the doctor, you have to be very, I wouldn't say aggressive, but I would say very much an advocate for yourself. And you have to share with the physician, it's been 6 months since this, it's been 1 year since that, it's been, and the reason why I say that is because, once again, if you have 15 minutes in an encounter, and you have high blood pressure, high cholesterol, high sugar, and you're coming with a form for handicap parking, and there's only so much time in that visit. So he or she just might renew all your medications, fill out your application, do an abbreviated physical, and move on to the next patient. So you want to be as efficient as possible and as prepared as possible for that encounter. So you could tell them, it's been this much time, can we review it? You have to have your agenda when you're going in, even if it's just for a general physical. Then the last thing I want to mention before I open it up to questions is, if you have a pre-existing illness and you have seen many doctors for, I don't know, let's just say a neuropathy, okay? Now you're seeing a new doctor and you're there for a general physical, or you're even there for the neuropathy. My advice to you is, not only is this lecture what you should be how to talk to your doctor, which is being prepared, being focused, being extremely educated, having your notebook with you at all times. But there's also what not to say. So you never want to say to your physician, oh, I've seen, a million doctors, I've tried every possible thing, nothing works, I guess I just have to live with this pain. And the reason why you don't want to say that is because the physician is, we all took the position of becoming a physician to help. We all want to help our patients. But once again, this is not 1990, this is 2021. If I have 5 minutes left of my encounter and you tell me that you have neuropathy and you've seen pain specialists and you've traveled the world and no one can find a solution, and you set the stage like that, I, as the physician, am going to be very discouraged. And I'm going to say, okay, this patient has toured the world. They've seen multiple physicians. They've failed treatment many times. What are the chances of me actually being successful? They're not. So I'm going to say, okay, well, I'm so sorry for, those failures. Let's try to make you comfortable. And that's the wrong thing. You don't want to discourage the physician. So what you want to say is, Dr. Smith, I have this neuropathy, and have your story. Have when the neuropathy started. What makes it better? What makes it worse? On a scale of 1 to 10, when you say it hurts, 1 being not so much, 10 being horrible, share that with them. Share how it interferes with your quality of life. It's not allowing you to drive. It's not allowing you to go to social events. Whatever the issues are, you definitely want to share that with them and say, I'm looking to see if you can share your expertise and if you can identify why I'm having this pain, and if we can work together in creating a plan. Now, if you say that to the physician, they get all pumped up and they're like, oh, this is a challenge. Yeah, okay, I'm interested in doing this. And even though you have 5 minutes left, I guarantee you that physician is going to embrace the challenge. And when they go home at night, they're going to research it and they're going to say, could it be this? Could it be that? They're going to be on your mind. They're going to be thinking about it because you said you want to work as a partner. You said you trust in their field of their knowledge, their expertise. So you're really putting the pressure on them to alleviate your pain, and they're going to want to do that. That's 2 different scenarios. One saying, I just have to deal with it. I've had this pain forever and no one can find a cure, versus, I believe that you can help find what is the problem and alleviate this pain. So those are 2 critical differences. So in summary, and I'll leave it for questions. In summary, when you're, the topic is how to talk to your doctor. When you're figuring out how to talk to your doctor, step 1 is be prepared. Have all your documents in one centralized location. You have to be aware of when your next screening, colonoscopy, or if you're still doing breast mammograms or pap smears or whatever you're still doing, you have to be the one to say, I am due for my cholesterol, I am due for my hemoglobin A1C, I am due for this, I am due for that. You can't rely on the physician or the medical staff to say, okay, you're due for it. Some of them are very good, some of them not so much, okay? You also have to review with them who your healthcare proxy is, because they're going to have to be the one to contact that person. Okay. And then if you're in obviously this is assisted livings, and if you're in assisted livings, then who's the power of attorney going to be paying for your assisted living in the event that you mentally or physically are unable or you choose not to do so. So those are important variables to have, already prepared for. And then not only do you have all your data prepared, but you also want to make sure that you have your questions outlined and you're very organized in what you're saying, and you're requesting physician to find the cause of your problem and then discuss together a treatment plan as partners. So that is, in summary, the best way to get the biggest bang out of your buck for your physician and make that time, that encounter, very productive. That will also make him or her want to continue helping you after the encounter is over. And overall, you'll get a better quality of care. So I know we have 10 minutes left. I'm going to open it for questions or concerns or comments.
Susan, now, how often do the electronic medical records contain the information you discussed that you should have in your folder? Is that something today that the doctor would have in his chart that you would have access to in your chart? Cleveland Clinic and Cleveland has my chart. Do they have that information, et cetera?
Yep. So electronic medical records do have information, but the problem is if you're going to a specialist that's not in that system, you may not have it. And you know, the labs should all be there. So yes, everything should be in your medical records if you're in the same system. But I personally like to have it printed out and in front of me so that I can say, okay, it was last done on such a time, and I'm looking right at it, and I could say, we're due, versus looking on the screen, and it's just easier for me to have it, hard copied.
Okay.
And once again, all those specialists that you're going to see.
No. Art just asked me, how often do you have to have a colonoscopy? Or is that for the physician to tell you?
Right. So that's for the physician to tell you. So we start at 50, and then based on what you see, it could be 5 years, it could be 10 years, and it depends on how many negatives you have. So yeah, absolutely. It's for the physician to make that determination. But remember, if the physician says, okay, you're 50 years old, I need you to come back in 5 years, he or she is not going to call you in 5 years and say, okay, Donna, you're due for your colonoscopy. It's been 5 years. They don't do that. Years ago, they might have, but it's just too crazy now for them to even do that. So that's where the lapse in care occurs.
Okay. This has been very informative, that idea about a health folder. Art was asking too, how long, and it's kind of what Larry said, are the electronic records kept? Like when he went to the hospital about a year ago, will that be since he went to the same hospital that our doctor is part of, will that always be available to him to remember, to see?
It should be. So, in Connecticut, Epic is a big company they use. And if anyone's in the Epic network, yes, it should be there. It should remain there. And every physician that is with Epic has access to that record. But remember, you're in you're in an office with the physician, and he has such little time. The chances of him going back and looking at who you saw and what you did and doing all that research is less likely because he has to open up the screens versus a paper chart. Years ago, when we had a paper chart, the front would say preventative medicine. It would just kind of jump right at you. And you could look at the old notes, and it was just so much more in your face, for lack of better words, versus electronic records where you have to click on this tab and click on that tab. You have to specifically search for that information rather than it jumping out at you.
Well, another thing, our GP, our general practitioner, recommended for Art to go to a cardiologist that's in the same system, or well, mainly the same hospital. That we have two hospitals, Freeman and Mercy, and so nearly all of our physicians are with Mercy, but Art's cardiologist that he's had for years and years is with Freeman, and he prefers to stick with him. And so they don't exchange their information very easily. And okay, but our GP, our general practitioner, said, well, be sure that anything he does is sent to me. But I don't think that we can guarantee that that's going to be done. But should he change cardiologist when he really likes the other one?
No, I think he should certainly keep with his cardiologist. And what you can do is you have all rights to your record. So what you
You're
could do
freezing
is you
on
could
me.
say, oh, can
You
you
broke
hear me
up.
now? Uh-oh. Am I back? No,
Right now, okay.
I'm back. So no, I think he should stay with the cardiologist he likes. And all you have to do is say, I want a copy of the consult note. And then, so this way, you have a copy, and then you could certainly photocopy it and send it to your physician, or you could bring it the next time you go. But that's why, unfortunately, nowadays in 2021, we have to be proactive. We have to, we can't depend on others. We have to do everything ourselves just to make sure it's done properly.
So the physician would give him a copy of his consult notes if he asks for it.
Yeah, absolutely. He has to. Yeah.
Okay. Thank you.
You're welcome.
Susan, generally for a senior, is it advisable for them to have someone else in the doctor's office when they have the visit? My wife recently went to an appointment, and one I went with her, and one I didn't go with her. Afterwards, the nurse said to me, she really would have preferred I have gone with her because some things were a little bit too complicated or she didn't understand. Is it oftentimes good to have, two sets of ears there?
So in general, it is good to have two sets of ears. The tricky part comes when there's elder abuse and you want that older adult to say, my son or daughter doesn't want me. So classic cases is the son or daughter doesn't want them going to assisted living to spend that money because that's less money in their inheritance. So they keep them home in an unsafe environment, which is very dangerous. And the patient would never say those words if the son and daughter were there. So I think it really depends. And in the ideal world, two, sets of ears are certainly better than one because, you're there to protect that loved one. But in the cases of children who don't have their parents' best interest, it's better off that the patient goes alone. So how do I handle that? I say two sets are better than one. And what I do is I interview my patient alone first. And then I say, is there anything that you want to share with me privately, or can we bring in your daughter? And then that gives the patient an opportunity to say anything that's in secret. And if there's no problems, then, you bring in the child or the husband or the wife or whatever it is.
That makes sense.
Yes.
Okay.
Right now, Art and I go in together on the doctor's appointments. And so far, we still have some mental faculties left. And so we do that. I know one of these days it may be different. We're going to, but all three of our sons are everywhere. We can't get, they're not close to it and they're all working. So.
Yeah, so you could certainly help each other out as much as you can. No doubt, yeah. All right, well, I think that's it. Unless there's, it's 4:00, unless there's any other questions, I guess I'll let you go to your happy hour. I don't want you to be late.
Oh, no.
And you too, Susan.
Thank you very much.
Thank you.
Good info.
Yes, thank you.
Thank you very much. This has been very informative. Thank you.
Thank you, and I'll see you next time.
Okay.